So, just to go through the details a little bit for people that may not be familiar, lean mass hyperresponders. This is a cluster of laboratory findings, essentially, that Dave was central in sort of bringing together, recognizing that a certain subset of people go on low carbohydrate diets. Their LDL cholesterols elevate what's considered significantly or dramatically. They have very low triglyceride levels. They have very high HDL levels, and they tend to be lean. And so he kind of named this cluster the lean mass hyperresponders. Now, one thing to understand is that lean can be a relative term. Now, the people in the study were all very lean. The average BMI, I think, was around 21. But in my practice, I see people who are lean compared to what they used to be, but maybe don't meet, that strict definition of lean, and they still have this hyperresponder response, this hyper response. So that's one thing to understand. But anyway, what Dave was able to do with a lot of hard work is get 100 of these lean mass hyperresponders and do a CT angiogram. So this is a very detailed look at what's happening in the blood vessels of the heart, and looked at the amount of plaque that they had to start with. And at the start of the study, these people all had to be on a low-carb diet for at least 3 years with documented cholesterol levels that were in a sort of, we'll call it normal range to start with, and then elevated significantly when they went on the low-carbohydrate diet. And on average, people had been on low-carb diets for 3.5 years at the beginning of the study. And so they did CT angiograms at the beginning of the study, and then they repeated them a year later. And what they found at the beginning of the study, year 0 we'll call it, they were able to compare this population to a separate population, not part of the study, that was matched for age, sex, a bunch of other factors. And the only real difference between the matched group and the study group was their LDL cholesterol levels. And they found that the amount of plaque in this group with a very high LDL level, on average, I think it was about 275, versus the group that had what are considered normal or low cholesterol levels, around 130. There was no difference in plaque at the beginning of the study. And then a year later, they then looked at plaque levels of the study group. Now, they didn't look at plaque levels of that other group. They didn't have any comparison for the follow-up study, and this is some of the controversy around the data that was just released. And what they found was that there was some increase in plaque. It didn't increase in everyone. The plaque levels overall are still relatively low, important to understand. And the most important finding, and what they emphasized in the first paper that has come out of that study, is that LDL cholesterol levels, or ApoB, which is another way of measuring LDL, did not in any way predict who had an increase in plaque, how much plaque it increased by, or how much plaque they had. So what they did find was predictive of increasing plaque over that 1 year was how much plaque you had to start with. So they titled the paper, it was called Plaque Begets Plaque, and their main conclusion was LDL ApoB is not predictive of plaque progression, but having plaque was somewhat, the people who had more plaque to start with were the ones that saw more advance. Now, what that tells me as a clinician is we should be monitoring plaque in people that have elevated plaque levels. So, step 1, screen for plaque. And many of you have probably heard me talk about the coronary artery calcium scan. And everyone says, well, what's one test you would recommend to everyone? It's the coronary artery calcium scan. If we're concerned about heart disease, don't worry about your blood work, but your blood work does not tell you whether or not you have heart disease. The only way to know whether you have heart disease is to look at the heart, and so get your coronary artery calcium scans. And again, I hear a lot in this community, people saying, but I'm on a carnivore diet, so what am I going to change if I have plaque in my heart? And the answer is, you're going to figure out maybe other things that you need to be looking at besides your diet. You're going to start thinking about, could I have some sort of toxicity, like mold, like heavy metals? Could I have periodontal disease? Could I have inflammation that's coming from somewhere besides my diet that is causing the plaque to form? So it's important to know whether or not you have plaque, but understand if you have plaque, it doesn't mean that you need to stop doing your carnivore diet. It just might mean there are other things that you need to look at. You also might need to think about, was that plaque there before my carnivore diet or not? And unfortunately, we can't get in the time machine and go back and get our CAC score before a carnivore diet. We then sometimes have to take the next step of, over time, get another scan and see if your plaque is getting worse or not. But what I don't want people doing is putting their head in the sand and just assuming that because you're on a carnivore diet, everything's going to be all right. And, then that leads to the next question of, well, but I can't find a doctor to work with. People don't, most doctors don't understand a carnivore diet. The sad reality is most doctors don't think that diet has anything to do with health. But, they go to their doctor and their doctor's freaking out because they're eating all this meat that the doctor believes is bad for their health. And how do I find a practitioner? And again, the answer is you put some work in. This isn't magic. You need to put some work into making your health better. So find a doctor or a practitioner. It doesn't have to be a doctor. I don't think just because people have certain letters after their name, that means that, they're the only ones that can fix problems. But if you're looking for a doctor, there are so many options these days, right? You can go to Sean, to Rivero, and, they see patients in all 50 states. Amanda Decker, who's a great nurse practitioner, in her practice over here, they see people in many states. You can come to my website if you want. I see patients in all 50 states. There are options for finding physicians. Go to the Society of Metabolic Health Practitioners. There's a directory. Maybe there is someone in your community, but it's probably not going to be the person that your insurance company told you, is the best doctor for you to see. Because all the insurance company cares about is that doctor takes their insurance and therefore it's going to cost them less. And again, that's an unfortunate reality that we all have to deal with these days. Yes, many of us have medical insurance, maybe by choice, maybe not by choice, and that insurance may not cover the doctors who can actually help you. And really said correctly, the doctors who can help you have made the intentional choice not to deal with the insurance companies anymore because they realize that the insurance company doesn't actually care about your health. The insurance company just cares about controlling costs and doing it in the way that they think medicine should be practiced. And for those of us physicians in the room, the reality is that we realize that the way that we want to practice medicine does not line with the insurance company, and so we've told the insurance company, we're not going to take your money anymore. It's not good. We want to deal directly with the people, and so you may need to make that choice to make an investment in your health, and I understand it might not be cheap, but it's probably less expensive in the long run than continuing to have medicine practiced upon you the way that they want it to be practiced. So put the effort in, make the intentional choice, get on the internet. Again, the community is powerful. And when Ken was talking yesterday, Ken Berry was talking yesterday about the power of the community and the power of the internet and social media, right? We need to leverage that power, and we need to all start helping each other and saying, these are the doctors that, have been able to help me, or these are the practitioners, the coaches, the nurse practitioners, the physician assistants, the naturopaths, the dietitians, whoever it might be. As long as they're building health around this message, they can help. And we can all help each other by starting to lead each other, right, to the resources that we need. And if you have a particular problem and someone else in the community has that same problem, and then you can start to say, well, this is how this is the path that worked for me, and these are the people that I chose to work with, and that's how we're all going to continue to build this message. And the last thing I just want to touch on quickly before opening up to questions is the greater movement that's going on around this, right? And we're starting to see what's happening on the political front. And we have people like Bobby Kennedy now talking about these things. We have Marty Makary, who's the new head of the FDA, talking about this. We have Jay Bhattacharya, the new head of the NIH. We have Mehmet Oz, Dr. Oz, fellow cardiac surgeon, now leading up CMS. And Casey Means has just been nominated as the Surgeon General. And it's amazing, right? It's amazing that we are hopefully going to start seeing changes that make this all easier to do and make it seem not so strange to everyone around us, all this stuff that we're doing. But again, don't wait, right? Government moves at the speed of government. These things are not going to be easy. There's going to be lots of fights. There's going to be pushback from the food industry, from the pharmaceutical industry, and everything else. So change starts with each one of you, and every one of you that is sitting in this audience has the power to change not only your own life, but the life of the people around you. So don't be shy about this. Don't feel shame about any of this. And like I said, rely on each other, reach out to the community, find the help that you need. Keep going. If you're not getting the answers that you need, just keep going. The answers are out there somewhere, and just put that effort in to find the answers you need. So with that, let's maybe open it up to some questions.
We'll take a few questions.
Hello, thank you for being here. I have a question. A lot of doctors, it doesn't matter if they're carnivore or vegan, they put a lot of faith on the calcium score. They say if you have a high LDL or ApoB, check your calcium score, and if it's 0, you're good. I don't believe that, because what are the chances that you have a 0 calcium score, but you have a lot of soft plaque buildup? The calcium score doesn't catch that.
Yeah, so great question about the calcium score. For people maybe didn't hear the beginning, the gist of the question is, can you have a 0 calcium score and still have trouble because of non-calcified plaque? The answer is yes, but it's actually pretty rare. The statistics show that if, and there's a caveat that I'll get to, but if you're a 60-year-old man, let's say, and you have a 0 calcium score, your chance of having a heart attack over the following 10 years is 1%. 1%, so pretty low. Now, if you're young, a 0 calcium score doesn't mean the same thing as if you're older. And yes, if you're 20, 30, 40 years old, you're supposed to have a 0 calcium score. That doesn't mean that there's no value in getting the calcium scan. If your calcium score is not 0 and you're young, that's a big red flag. But I don't think it's necessary for everyone to get a CT angiogram, which is the more detailed test that shows that soft plaque. And I also don't think that if your calcium score is 0, you can just kind of, you are reassured that heart disease is probably not going to be a problem for you in the next 5 to 10 years. It's important to follow it, repeat that calcium score. One of the things that I see as a problem in medicine is many doctors think the calcium score is a one-time thing, and it's not. It's a trend. It should be repeated. It should be followed over time, and depending on what your score is will dictate how often you might want to check that.
Dr. Ovadia, can you speak to the significance of, I think it's a lot of heart disease gets blamed as a genetic problem, but is it lipoprotein A, little a? Can you speak to that significance and maybe the importance of getting tested for that?
Yeah, so lipoprotein A is a under-recognized risk factor for heart disease. Lipoprotein A is, your lipoprotein A level is largely genetically determined. Not completely, but largely genetically determined. However, just having an elevated lipoprotein A level does not destine you to heart disease. Lipoprotein A becomes problematic in the environment of inflammation, particularly insulin resistance as well. And then the problem with the way that most doctors understand lipoprotein A is that lipoprotein A is a cholesterol-carrying molecule, right? It is an LDL particle that has this extra little protein on it called lipoprotein A. But it's important what that protein does. Lipoprotein A causes that cholesterol molecule to interact with the lining of the blood vessel, the endothelium, and predisposes to blood clotting. So lipoprotein A is a problem not because it's cholesterol, but because it promotes blood clotting, and therefore the way to combat it, if you have elevated lipoprotein A, is do something that's going to help prevent blood clotting, and that might look like aspirin or nattokinase, which is a natural supplement that has blood helps prevent against blood clotting. But genetics. Many people have probably heard the saying, right? Genetics load the gun, but your environment pulls the trigger. Genetics are rarely truly destiny. You can always improve whatever genetic window you've been dealt by improving your lifestyle. And so focus on what we can change, right? We can't change our genes currently. We may not want to change our genes with a lot of the stuff that's going on, but focus on what you can change, and that's your environment.
One more. Uno más. And then you talk to him afterwards.
Dr. Ovadia, my husband actually had a very bad clotting disorder that he threw pulmonary embolism. So my husband threw pulmonary embolism. He's no longer living, not from that. But I have 3 daughters, and I've told them they absolutely cannot go on birth control. We've had strong talks. Would them getting lipoprotein A checked be a good indicator? I'm sorry, this is the first time I'm hearing about this, so my mind is spinning.
Yeah, so I would put lipoprotein A on the list. It's not the only thing. There are actually there were many different blood clotting factors that you might want to look into with that family history. You also might want to think about, right, pulmonary emboli, blood clots forming. Sometimes can be, from a genetic predisposition, but may also have a lot to do with, diet, lifestyle, other things that were going on. So that would be a situation, again, where, just finding a good doctor who understands that and can help you and your daughters understand that would be good. But yeah, I would put lipoprotein A on the list of things to check because it may be one of the indicators of a predisposition to blood clot. Yeah, so very good.
Dr. Ovadia fixes hearts, and what he's giving today, hopefully you won't need your heart fixed. So thank you, Dr. Ovadia. Appreciate you so much.
Thank you.